Hello, my name is Kaylin Matos, and this will be my lab for presentation of inspection and assessment of the GI abdominal area on an infant. I would start by introducing myself to the parent, letting them know I'd be their provider for the day and that I was going to do a quick assessment of their abdomen, and it would take about 10 minutes in this particular case. You would start by having the patient be supine. In an infant, you would want them down to their diaper, and a pediatric patient, you would just want them to lift their shirt up to the nipple line. And the order of it, assessment would go inspection, auscultation, percussion, and palpation. And you would want to leave all the physical inspection towards the end because percussing and palpating could create unnecessary or inappropriate sounds that would be misleading while you're auscultating. I would start by inspecting his abdomen, which is protuberant, which I hope I was pronouncing that right, which basically just means that because his abdominal walls are weak, which is appropriate for his age, he's a little rounded. But I don't see any signs of diastasis recti, which would be bulging in his midline area. There's no scratches, bruising, lesions, no outward signs of abuse, no Cullen sign, which would be bruising kind of in the near the costovertebral angle above the umbilical area, which could indicate abdominal bleeding, no striae or stretch marks, and no obvious signs of lipomas, which were probably more so felt during palpation. And there's also no signs of hernias in the costovertebral area around the umbilicus or in the inguinal areas near his diaper. I know you like that. But how about my finger instead? Then I would move on to auscultation, I believe. Believe so, yeah. I would move on to auscultation, and you'd want to listen in all 4 quadrants for bowel sounds. You would want to listen in. Oh, his abdomen is also symmetrical. There's no pulsations, signs of peristalsis. I'm unable to detect any peristalsis movement or pulsations. And then when you move on to auscultation, you listen in all 4 quadrants, the right upper, left lower, right lower. It's always good to kind of go in a somewhat of a clockwise motion. You'd want to listen for at least a minute in all quadrants, because it may take some time to hear a bowel sound in some cases. It would sound like a gurgling noise. Very active noises is hyperactive, and that could be indicative of diarrhea. And hypoactive sounds could be obstruction or constipation. You also want to listen for bruits close to the costovertebral angle, for an aortic bruit, iliac artery bruits, and femoral bruits. You also would like to listen for friction rubs along the costovertebral angle as well. It is, of course, hard to hear bowel sounds when a child can be fussy, so you would want to have the parent calm as best as possible. Maybe give them a toy or a pacifier, although in general, infants are very comfortable with being touched on their belly. Then you would move on to percussion, which in an infant you normally wouldn't percuss, but in a pediatric patient, an older pediatric patient, you would percuss in all 4 quadrants: right upper, right lower, left lower. Tympany is normal as gases flow, and it would become more dull as you went outward toward the lateral sides. You would also percuss in an infant. You would probably, in an infant or a pediatric patient, you would actually probably do the scratch test, where you would go towards their right lateral side, right midclavicular, and try to feel for the presence of their liver on that side. Or you could percuss upward from the right lower quadrant, right midclavicular, upward until it goes from a tympanic sound to a dullness, and then down from the nipple line to you hear a change from tympanic to dull, to kind of also find the span of the liver. Spleen could be percussed going towards the left lateral side to the axillary side, to the axillary line on the left side. I know, bud. I know, I'm sorry. And then you would also percuss the flanks for ascites. Okay. You're probably tired. It's probably your nap time, right? Probably your nap time, yeah. There we go. We know you like the soft stuff. We know you like the soft stuff. Yeah. So once you percussed for organ placement, span, to check for gas and ascites, you would move on to palpation, and you would do light palpation and deep palpation. Light palpation is just for more like superficial masses. Specifically, like superficially, you could probably feel some lipomas along the skin. In an infant's breast area, you could they're more so rounded due to the subcutaneous fat, and then in the first 1 to 2 weeks they may produce white milk, and that has to do with the extra levels of estrogen that there's still in their body from being in their mother's womb and getting in utero, but that should resolve itself within 1 to 2 weeks. He's a 6-month-old, so he does not have that. Once you moved on from light palpation in all 4 quadrants, you would move on to deep palpation, looking for any abnormal masses, like an olive-shaped mass, which could indicate pyloric stenosis, splenomegaly, hepatomegaly, things of that nature. You would do deep percussion in the right upper quadrant midclavicular line, right midclavicular line for the liver on the right side. And then for the spleen, you would go to the left lateral side. You would place one hand under towards the back, and then press deep with your right hand to feel it in towards like the left midclavicular line or left lateral side. In an older pediatric patient, you might have them breathe in so that it pushes the spleen up so you could feel it more. And then while on the left side, you'd also feel for posteriorly the kidneys, and then back to the right side to feel the right kidney. I know. I didn't feel any, his spleen or liver did not feel enlarged. I know, you're so tired. There we go. You would then also inspect I apologize. You would also then inspect and do like certain physical signs to indicate appendicitis, for instance, like McBurney's sign, where you go to right lower quadrant and do rebound tenderness, where you'd press in. And then if the child indicated any sort of pain upon release, that could be an indication of appendicitis. You can do the, I'm gonna pronounce this wrong, obturator muscle, did I pronounce that correctly? Where you would flex the knee upward. And if there was any sort of pain or indication that could mean rupture, you would also do the iliopsis muscle test, where you would lift the leg up in an older pediatric patient, of course, and press down as they lift up. And if they felt any sort of pain with that, that could also mean appendicitis or appendic rupture. Hoping I didn't miss anything else. In an older pediatric patient, you would probably also want to palpate for the bladder right above the pubic bone. And then all pediatric populations, you would want to feel for the femoral pulses on both sides, not at the same time, to make sure that they're strong and palpable at +2. And I think that concludes my abdominal GI assessment.